السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم أجمعين. This is good evening everybody, Saudi time, good afternoon US time. This is Dr. Imad Al-Badawi. I'm a consultant pediatric dentistry and at King Abdullah Medical City, Jeddah, a member of the Saudi Society of Pediatric Dentistry. On behalf of the society member, I guess I'm not sharing the screen or what. Okay. On behalf of the Saudi Society of Pediatric Dentistry, I would like to say thank you to Dr. Ali Al-Haidib for accepting our invitation to moderate the session for today. Dr. Ali is a legend in pediatric dentistry specialty in Kingdom, Saudi Arabia. He's the first chairman of the Scientific Board of Pediatric Dentistry from 2004 to 2012. Currently, Dr. Ali Al-Haidib is the Dean Dental College at Saud bin Abdulaziz University for Health Science. So please welcome Dr. Ali and to start the 10th webinar session for the Saudi Society of Pediatric Dentistry. Okay, Noura, can you share the screen, please?
Thank you, Dr. Imad. Assalamu alaikum jami'an. Good evening, everyone, and good afternoon, Dr. Yepes. And I hope everyone and your loved ones are healthy and safe during this pandemic that has affected the world actually during the past 6 months. As this pandemic causes social distancing between individuals, our human innovation and initiatives worked in adapting the technology to serve the science, knowledge, and learning. And here we are tonight from our homes or from our workplaces like Dr. Yepes to exchange experiences without visa or traveling time and cost. And we can return to our daily work without delay. I think this is one of the positive outlook of this pandemic. In my opinion, it made the people more cohesion, and the world and the society became closer spiritually as much as it is caused a physical social distancing. I would like to thank the Saudi Society for Pediatric Dentistry for arranging this webinar and its important topic. And thank you, Dr. Imad, again for such nice introduction. And I'm delighted to be a moderator with you this night and introduce one of the well-known speakers in the field of dentistry in general and pediatric dentistry in particular. Our speaker tonight is Dr. Juan Yepes. Dr. Juan Yepes is an associate professor in the Department of Pediatric Dentistry at Indiana University School of Dentistry and an attending at Riley Children's Hospital in Indianapolis, Indiana. Dr. Yepes is a dentist and physician as well from Javerina University at Bogota, Colombia. In 1999, he moved to the US and attended the University of Iowa and the University of Pennsylvania, where he completed a fellowship and residency in radiology and oral medicine, respectively in 2002 and 2004. In 2006, then he completed a master in public health, and in 2011, a doctoral degree in public health, both with emphasis in epidemiology at the University of Kentucky College of Public Health. In 2008, he completed a residency program in dental public health at University of Texas Baylor College of Dentistry. Finally, Dr. Yepes completed a residency program and a master in pediatric dentistry at the University of Kentucky in 2012. He is board certified by the American Board of Pediatric Dentistry, Oral Medicine, and Dental Public Health. He has many years of experience in medicine, medically compromised children, and dental protocol diagnosis and radiology in children, and he shares these experiences in outstanding lectures as of today. Dr. Yepes' presentation in the next hour or so will be on pediatric restorative dentistry with the title of New Frontiers in Dental Material to Use in Pediatric Dentistry. Dr. Yepes, welcome, and mic is yours.
Well, you know, Dr. Ahmad, Dr. Ali, and everybody who is listening to this webinar, first, can you listen me?
Yeah, Nora, can you change the screen, please, Nora? Nora.
Doctor, please, can you share your screen?
Yes.
Can you see my screen?
Yes, now.
Okay, well, so the first thing is I want to thank you, and I want to thank everybody listening to this webinar. I never imagined in my life that I will get invited to give a webinar from, you know, different places around the world. And it's really an honor to be here tonight from you and this afternoon here in the US. I want to thank everybody. I hope everybody's doing well and your families are healthy. And this is a wonderful opportunity to share some knowledge and to share some ideas about pediatric dentistry. And what we are going to talk tonight, I will keep saying tonight because that's probably, I'm the only one in the afternoon time. So what we are going to talk tonight is about dental materials in pediatric dentistry, which honestly is an interesting topic, especially now in the middle of the coronavirus pandemic. And one of the reasons is because some of the materials actually offer us as a pediatric dentist the opportunity to provide some treatment without the use of aerosols. And as everybody is fully aware, one of the issues of dentistry during this pandemic is the potential of the virus to be part of the aerosols when we are using the highest speed, when we are using the lowest speed, when we are using the cavitron. So this lecture, and I hope that I have students and I hope that I have residents. I am a teacher, and residents and students are the reason of my life. So I hope that you are going to learn something. I'm sure you know pretty much everything that I'm going to talk today. I'm sure you know that, but I hope that you are going to take some of this knowledge and you are going to apply that to your daily life. And as I said before, especially now during the pandemic, when we need to try as much as we can, I am not against the use of aerosols during these days, but obviously with the new options that we have in restorative dentistry for the pediatric patient, some of the options, for example, resin infiltration. We are going to talk about resin infiltration in a few minutes, but resin infiltration is a nice option that we have that we don't need to use the highest speed. And we can decrease the amount of aerosols that we generate in the dental office. We probably are going to get less exposure to the virus, that we can have a cross-contamination between the patient and us. I need to say before I start, I visited the kingdom a few years ago and I love it. I have a great time, and it's such an honor that you think about me for these webinars. Really, I wish I have the time to check your hands and to go there and see you face to face. But please take this as a big thank you. And I hope that in the near future, once we move out of this pandemic and once we kind of move back to our normal lives, we really don't know when we are going to have these normal lives that we have back in January of 2020. But I truly hope that someday we can see each other, that we can be in a conference room, that I can be walking from the podium to the aisles and I can see your eyes and I can ask you questions. And, you know, I really believe that webinars are wonderful, and thank you to webinars, we are kind of navigating these times, but there is nothing like the face-to-face lectures. I have a great time in the kingdom. I really have a great time. I provide a lot of lectures, and I was invited to wonderful restaurants, and I was in the capital, beautiful city. And so I really cross my fingers, and I'm doing that I will have the opportunity to come back. So thank you so much. I'm going to start the lecture. As I said in all my webinars, if you want the PowerPoint, you just need to send me an email. I will tell you the email later. And then I'm ready to start. I also ask you, if for some reason we have a technical issue, let me know. I don't want to talk for an hour and a half and then, not having any opportunity to, and then at the end, I just realized that nobody was listening to my webinar. So please, if something happened, the slides are not moving, my voice is now, just let me know and I will try to fix the issue. Okay. So new frontiers in dental materials to use with pediatric patient. That's me, that's my name. I will, on July 1st, I will change my name from associate professor to professor. I was promoted after 1 year of promotion process. I got my promotion a few months ago, and my promotion to effective professor is July 1st. So I will, in a few weeks, I will change my title of associate professor to full professor with tenure here at Indiana University. So I also have an Instagram account when I share, it's only about pediatric dentistry, and I do a lot of otopathology, otoradiology, and of course, dental materials. So this is the main goal that we have from today. We want to increase the knowledge and understanding of the most common materials used in the field of restorative dentistry for the pediatric patient. Believe me, every single material that I'm going to mention today, you probably know more than me. So be patient with me, because I'm sure you're sitting at some point, you are going to say, well, I know that. So because I didn't run a pre-test to know your knowledge before the webinar, I don't know, you may actually are an expert in silver diamine. You may are an expert in resin infiltration. You may are an expert in all the things that I'm going to talk. So if you believe that and you know a lot, just be very patient with me. This is the agenda that we have. We are going to talk about, first of all, practical guidelines and non-restorative treatment for caries lesions. Then I'm going to talk a little bit about silver diamine, the whole technique, sealants, resin infiltration, resin-based composite glass ionomers, and then we are going to finish talking a little bit about Benton substitutes. So we are going, this is the agenda, and I will go point by point. I will, to make sure that this webinar is a good learning experience, I'm going to speak a little bit more slow, and that will help so we can have a full understanding and we can communicate. So we are going to start with the practical guidelines of non-restorative treatment for caries lesions. This is something that we pediatric dentists, we really need to be fully aware. And basically what I'm going to use as a guideline for this first section of my webinar is this article that I really, the article was published in 2018, so a couple of years ago. But all my residents here in our program in Indiana, it's almost mandatory to be experts about this article. This is evidence-based clinical practice guideline on non-restorative treatment for caries lesions. Honestly, this article is probably the best update meta-analysis guidelines of non-restorative techniques for dental caries. I can imagine when I was in dental school, I graduated from dental school in 1987, and I graduated from medical school in 1990. I'm sorry, I graduated from dental school in 1992, and I graduated from medical school in 1998. So in 1992, when I graduated from dental school, I can imagine if this article will be published at that time. I mean, at that time, the way that we used to believe about restorative dentistry was always you need to take a high speed with a burr, and then you need to drill. The restorative dentistry in the 80s, and I know some of you, probably just be born 25 years ago. I'm 50, so I have been through different phases of dentistry. And believe me, in the 80s, the idea was every single time when you see a dental caries, a kind of a change in the color of the enamel, the only option that you will have is to take the highest speed and make a hole and then put some material there. It was like that. Caries, make a hole, put the material. So, moving back to 2020 and 2018, it really, this is a change in the mentality. And I hope that the residents who are listening to my webinar, and again, I hope that I have some residents, I hope that the residents belong to these new times that we fully understand that we can, as a pediatric dentist or as a dentist, we have other alternatives besides just taking the high speed and drilling a class 1 cavity or class 2 or class 3 or whatever. We have other options, and believe me, the other options could be as good as the traditional high speed. And remember what I said just a few minutes ago. I believe now that we are trying to decrease the use of aerosols, I really believe that this idea of non-restorative treatment for caries lesions is even more important, because that means that I can provide some treatment without taking the high speed and making a hole, and that treatment will be as effective as doing just the cavity. So I will invite everybody to have some time. This evidence-based article was published in JADA, the Journal of the American Dental Association. Is free. If you go to JADA, the website, and then you just write, Dr. Slayton is the main author, which is a good friend of mine. And all the members of this panel are very well known, either public health dentists or pediatric dentists. So these evidence-based guidelines, they go around 3 questions. So we are going each question, and I will, pretty much I will give you the summary of the article. The article is a lot longer than just only 4 or 5 slides, but because we don't have 7 hours to cover this webinar, I can't imagine talking by 7 hours. Believe me, I can. If you invite me to talk for 7 hours, I probably will be talking for 7 hours. I just need some water. But let me just give you a nice summary of this evidence-based article. So the 3 questions are, so the first one is, what is the best way to stop cavitated, listen this, cavitated. In the 80s, I can imagine in 1987, 1988, 1989, if somebody will challenge the idea of options besides using the highest speed to stop cavitated coronal caries. Honestly, in the 80s, the only option, you have a cavitated coronal caries, was to take a 330 burr or 245 or whatever you use, make a hole and put the material. So the first question is, to stop a cavitated coronal caries lesions of a primary or permanent teeth, what is the best option? So we have 3 options, and they look at silver diamine, silver nitrate, or sealants. So they look, because this is a meta-analysis, they look at a lot of articles, and as you know better than me, when you do a systematic review of meta-analysis, you really look for the best evidence. And the way to reach the best evidence is by consensus, using criteria. It's not like, oh, this article smells so good and we need to include it. So at the literature, and they look for high evidence articles that they can extract and they can use to come with these guidelines. So they found about 4 studies. I don't remember how many studies they review, but I'm sure they review a lot more than 4. But at the end, only 4 studies really meet the criteria, about 2,000 participants. And then after 30 months of follow-up, which in my opinion is a long time, I know 30 months is about 2.5 years. And I know some of you maybe would like to see a study that follow patients for 7 years or 10 years or 15 years. But you know, one thing is I want a 10 years follow-up, and different thing is to really go and do a study doing like that. So after 30 months of follow-up, the use of 38% of silver diamine solution applying twice a year resulted in 1.13 times greater chance of stopping advanced cavitated lesions on primary teeth than the use of 38% just once a year. So the conclusion of this was, if you apply twice a year silver diamine, that is more effective than applying only once a year. And I really don't know, and I don't know why I didn't ask. You know, we have like 10 minutes before the webinar start, and I didn't ask about if you are using in the kingdom, if you are using silver diamine. And I am one of the chairs of one of our PhD students here in Indiana. He is from the Kingdom of Saudi Arabia, and I'm the co-chair of his thesis. And we became good friends, and I don't know why I didn't email him to ask, because he really knows if in the kingdom silver diamine is very popular. Here in the States, silver diamine came in 2016, something like that, 2016 to 2017, and is becoming more and more popular. And we are going to talk about silver diamine in a few minutes, and I want to share my opinion about silver diamine. And this is Yepes' opinion. This is not really the American Academy of Pediatric Dentistry or Indiana University, just my opinion, and I want to touch base with that in a few minutes. So the recommendation to stop coronal caries, cavitated, I want to emphasize the term cavitated. The way to stop cavitated coronal lesions on primary permanent teeth is the use of silver diamine 38% twice a year. And it seems to be better than the use of sodium fluoride 5%. So the second question is to stop non-cavitated. coronal caries lesions on primary or permanent teeth. So they look at sodium fluoride, stannous fluoride, APF, polyols, amorphous calcium phosphate, casein phosphopeptide, silver diamine, resin infiltration, or carbamide peroxide. So they look at different options of the best way to stop non-cavitated coronal caries lesions. And they look at 8 studies, about 700 participants, and these are the recommendations. So when the non-cavitated caries lesions is on permanent teeth, when it's in occlusal surface, they found that the sealants, interesting, sealants, plus 5% sodium fluoride varnish every 3 to 6 months, or sealants alone over 5% sodium fluoride alone, or something that we are going to talk later on, resin infiltration plus sodium fluoride 5%. Again, 20 years ago, this was really crazy. I mean, placing a sealant over a non-cavitated caries lesions was almost out of the picture. So to arrest or to stop or reverse non-cavitated caries lesions on occlusal surface of permanent teeth, again, the recommendation was sealants plus 5% sodium fluoride. The next point is, what is the best option for interproximal caries lesions? And this is really something that is very interesting, because very often in pediatric dentistry, you take a bite wing and you see these interproximal caries lesions who are in the enamel, just getting into the dentin. And so you look and say, well, besides just taking the highest speed and drilling and making a class 2 restoration, what other options I have? So the question is to arrest or to stop reverse non-cavitated caries lesions on interproximal surface on primary and permanent teeth. The best option was 5% sodium fluoride every 3 to 6 months. So especially for the residents who are listening to this webinar, once you apply the fluoride varnish, remember that is as critical as to apply the fluoride varnish is to take a dental floss and go in between. And I always do that with my patients in my private practice. And I always tell the residents to do that. You know, it's not just only painting the teeth around with the sodium fluoride, it's also getting with the dental floss and making sure that you are moving material or moving the fluoride into the interproximal area. Or resin infiltration alone. And again, we are going to talk about resin infiltration in a few minutes. How about when the decay is facial or lingual? So the best way, this is interesting, it was a little bit shocking for me that the best evidence based on reviewing all these studies, the best way to stop or reverse non-cavitated caries lesions on facial or lingual in primary or permanent teeth is 1.23% APF gel every 3 to 6 months, or what we use regularly is the fluoride varnish 5%. So at the end of these evidence-based guidelines, there is a nice algorithm. I love algorithms, and I do that for oropathology, I do that for radiology, I do that for different things in my life. So this is an algorithm of the best non-restorative treatment for caries lesions in primary teeth. So if you have a decay on the coronal surface, if it's occlusal, if it's in the occlusal surface and is cavitated, which means that you take a spoon and then you can, you feel that dentin is soft. So the best way is, or the best way to stop that cavity is the 38% silver diamine. Now I want to say something here very slow because I want everybody to be in the same page. Listen to this. So this is the best way to stop the decay. Stop the decay. Stop the decay. 38% silver diamine. But one thing is to stop the decay, and a different thing is to restore the tooth. So imagine if I have a primary molar with decay, if I want to stop the decay, I can use silver diamine 38% according to these guidelines. So I can use that, and we are going to talk about silver diamine in a few minutes. But obviously, I'm going to stop the decay, but I'm not going to return the functionality of that tooth. If I want to return and restore the functionality of that tooth, I need to do either I need to do a crown, or I need to place a material, or I need to do something. And again, this is very important because and I am a public health dentist. I'm a board certified public health dentist by the American Board of Dental Public Health. I have a doctoral degree in public health, so I understand that. I understand the concept that you can go and, you know, you go to the community, you can paint with silver diamine and 38%, and yeah, you can stop cavitated caries lesions. Now you need to be careful, because if the caries lesions is really getting into the pulp, you are not going to really change the outcome. You can paint for 3 hours, but if the lesion is already into the pulp, you know, that patient will suffer pain or whatever. But my point is, and you can read in this algorithm, you can apply the 38%, you can do that and you stop the decay, but you are not giving back the function of the tooth. And in order to give back the function of the tooth, you need to restore the tooth. So, conclusion. And I wish I will be in Saudi Arabia right now so we can have in a big table, we can have a nice discussion about this. I need to be very careful. I like the use of silver diamine, but the silver diamine is not going to return the function of the tooth. And we have teeth in the mouth. You can see it. We have teeth in the mouth to chew, to bite. So I feel bad if I have a child, if I have a 4-year-old with decay in the lower second primary molar, lower second right primary molar, big decay. And, you know, it's not in the pulp. I take a radiograph, it's not in the pulp. I can use silver diamine. But honestly, that child will still having a problem when she's or he is chewing over that side, because that tooth is not back to the function. Again, that's my opinion. But let's go back to the algorithm. So you have interproximal decay and it's non-cavitated. You can use resin infiltration, or you can use sodium fluoride. If it's interproximal and it's cavitated, the recommendation is to use silver diamine 38%. My problem is, how are you going to take the silver diamine to the interproximal area? I think so that's kind of difficult. And then this is the algorithm for permanent teeth, which is not really a big difference from the algorithm for primary teeth. And if it's any program director listening to this webinar, I think so I'm not a program director, but I am a faculty with the residents here. And by the way, something that I would love to do is to establish an exchange program between the Kingdom of Saudi Arabia pediatric dentist residents and us in Indiana University. We, here in our department, obviously after the COVID-19 is out of our lives, I would love to see some of the residents from the Kingdom coming to spend with us some time. Not because we do the things better, we do maybe the things different. And I'm sure you are doing the things better than us, but sometimes, you know, the possibility to see how the things are done in different places, I think is important, because then you realize that the way that you do the things in your country is as good as you can imagine. Sometimes we don't believe the things that we do in our own country, but also you can learn a little bit of issues in pediatric dentistry that we may do that different. I usually have 2 or 3 residents almost every month coming from different countries of the world coming here to Raleigh. And I hope to return to do that. It's a very straightforward form that we need to do. And I will welcome any resident to come here and spend some time with us, a week, 2 weeks, 3 weeks, whatever you want to do. Okay, so let's go with silver diamine. I'm sure in the Kingdom, and I am very aware of the statistics of the Kingdom of Saudi Arabia in terms of oral health, because I was one of the consultants of the survey that was actually completed in the Kingdom of Saudi Arabia about 1 or 2 years ago. So I was one of the consultants through one of our PhD students here, who is from the Kingdom, the one that I mentioned, and I helped with the oral questions. And I know this was a health survey, it was not just only dental, but I helped into the design of the oral questions. So I know that in the Kingdom, as well as here in America, this picture is from one of my patients in my office, we see a lot of dental caries. So this will be the extreme of restorative, just going ahead and putting silver crowns everywhere. So that is the extreme restorative. Obviously, to do that, you need to drill, and as you can imagine, this child probably will need to be under general anesthesia. So let's talk a little bit about silver diamine. So we have commercially available 2 different silver salts for caries management. In the United States, we have 2 different salts or silver salt products available in our country for caries management. Probably the most popular and the one that I'm going to use is the silver diamine fluoride solution at 38%. And I will say, I know some of you may know 3 times more about silver diamine than I know. So if you belong to that group, this is a good time to go and have a cup of coffee or bring your food to the webinar so you can use this time in something different. In Canada, in our neighbors, silver diamine was approved about 3 years ago. So silver diamine became commercially available in the United States in 2015. It was approved by the FDA in 2015. Interesting, the FDA, which is the Federal Drug Administration, they gave the clearance as a hypersensitivity solution. So it was not really approved for the treatment of dental caries, was approved for hypersensitivity. Interesting enough, here in the United States, the FDA, when they publish the guidelines, silver diamine is not recommended for the use in people under the age of 21. So we are using silver diamine, what we call here off-label, and clearly I'm using silver diamine at any age. And so this is the silver diamine at 38%. It's a clear solution with a pretty basic pH, 8 to 10. If you put any bacteria, mutants, or whatever is in that cavity, and you just give a few drops, you tell mutants, open your mouth, and you put a few drops of silver diamine, you kill mutants and all his friends. That's a pretty high pH. And I wish I can do a quiz. I wish I can send you some exam questions to the program directors, because I have interesting, we are going to talk about some materials later on this webinar that they also have a pretty high pH. And there are 2 dental materials that we can use in pediatric dentistry besides silver diamine, that they have a very high pH. And again, that's one of the antimicrobial properties of these 2 materials. So if I will be a program director, I will be asking my residents, please mention 2 materials that we use very common in pediatric dentistry, that they have a pretty high pH, very alkaline pH, and actually between 10 and 12. So 2 materials, that's the question. But silver diamine is 8 to 10, it's a metallic taste. We don't want to taste that. This is the composition of the silver diamine fluoride. The question is, silver diamine fluoride is not 38% fluoride. And that's usually the mistake when I ask my residents and I say, hey, what do you think is the concentration of fluoride of the silver diamine fluoride? 38%. So they look at my eyes and, well, silver diamine fluoride concentration of fluoride is 38%. Wrong. The concentration of fluoride is 5 to 6%. And so really the 38% comes of the silver plus the ammonium. So when you add silver, it's about 24%, and ammonium, which is the NH3, is about 7.5%. So when you add the silver and the ammonia, that's the 38%. And fluoride is about 5 to 6%. And then 62% is just water. So we have a challenge as a pediatric dentist, so I make sure maybe somebody is a dentist listening to this webinar, not necessarily a pediatric dentist, but we have a lot of challenge when we are working with little kids. Sometimes, you know, when I have kids, and believe it or not, this happened to me. I was in my private practice a few days ago, and I saw at least 2 or 3 patients under the age of 3. Listen, under the age of 3, little ones, 2.5, 2-year-old with decay in all the front teeth. So that's very challenge. You know, a child at that age is not going to say, hi, Dr. J, I'm so happy to be here, jump into the dental chair and then open the mouth for 6 hours. I mean, they are not going to do that. We need to do a lab to lab, and it's a battle even to look at the mouth. So obviously, under the age of 3 is very challenged. Here in America, behavior management is very related with medications. Here in America, and I know because I travel around the world and I know pediatric dentists from different countries of the world, I know in other countries, you know, behavior management is more towards, you know, other techniques, tell, show, do, and voice control and other techniques. But here in America, we are very, very medication oriented. So either we do sedation, we do IV sedation, we do GA, general anesthesia. But when you have a kid under the age of 3, is very challenging, because generally speaking, we don't want to put kids under general anesthesia when they are younger than 3. And so when we have that kid, so silver diamine became a pretty good option when we have kids under the age of 3. I don't see elderly, but if you also work with elderly, silver diamine is an option. Also medically compromised. Sometimes patients are with heart issues. And by the way, I would love to give a webinar. I hope that you can invite me again to give a webinar about medically compromised children. I'm a physician, so I love to talk about all different medical problems and how they can impact the practice of pediatric dentists. We need to find a way, if you don't mind, to have a webinar, which really will be 2 or 3 webinars about medically compromised kids. So you have a kid with medically compromised that is not too easy to take it to the OR. So silver diamine is an option, and also uncooperative patients. So I have an example here. You know, this is a very difficult access place. And so trying to fix that, this is a patient with cleft palate, and try to fix that is honestly challenge with the drill, with the high speed. So silver diamine honestly is an option. So let's talk a little bit about the silver salts. So the silver, I'm sorry, I clicked too fast. So the silver ion is a very antimicrobial substance. Consequently, silver is used in products from water lines management to home cleaning clothes. So silver is not just only used for killing bacteria within the cavity. Silver is used for cleaning water lines and cleaning clothes, and is coming in different household products. So the silver nitrate is the less expensive salt of the silver, is commercially available in different concentrations. And as you know, silver diamine came to the United States in 2015, but silver diamine in other countries in the world has been used forever. Years ago, I spent some time, 3 months in New Zealand, doing a project with the New Zealand Board of Dentistry. In New Zealand, they have been using the silver diamine for years and years and years. As well as some Asian countries, China, Japan, I don't know, Saudi Arabia, when silver diamine was introduced, but we really here in the United States, we came late. And this is a nice chart. You can tell that up to, you know, in the 1900s, silver diamine was used for caries management. And then in Japan, they start to use it in the 1970s. In Australia, between the 1970s and the 1990s. And then in the 2000s, we start to see a lot of randomized controlled clinical trials on the use of silver diamine. So a little bit about why the silver seems to be so bad for the bacteria. Well, the silver interacts with the thiol groups of the proteins and the DNA of the bacteria. So the silver inhibits the respiratory cycle of the bacteria, inhibits the cell wall synthesis, and also the silver blocks the cell division. So it really is a very potent antimicrobial. I am not going to spend a lot of time here because honestly, you know, we don't have the time, but if any resident is interested to have my lecture, I will give you my email so I can send you the PowerPoint. But this is a nice summary of different studies about silver diamine. And if you don't mind, I'm just going to kind of pick some of the studies. And as soon as I click, you are going to see a yellow kind of a banner coming with something that is important for our discussion. So I will just pick up 4 for illustration. The first one is, this is a study that look at different concentration of silver diamine. They look at 38% and they look at different concentrations, and they found that the best concentration of silver diamine is 38%. And it's a very well-designed study in 2005. The second one is, this is a study that they look at if it's good to excavate the lesion before or just put in the silver diamine without any previous excavation. And this study found, and again, I don't want to tell you that this is the only study and this is the best study and you need to follow this. You can, I'm sure in your residency program, you had lead review, and I'm sure you review a lot of articles about silver diamine. But based on this article, something interesting is there is no advantage to excavate the caries lesion. So the article conclusion was that you can just put the silver diamine without any previous excavation. Also, one more is there is an advantage of repeated applications. In my office, I'm putting silver diamine, and usually I try to see the patient 3 months later. And then depending how it responded, the patient, I will reapply. So there is no question that once application a year is probably not as effective as applying 2 or 3 times a year. There are some remaining questions about what is the optimal protocol for applications, how often we need to reapply the silver diamine. Can we use silver diamine for caries prevention versus stop the decay? What is the long-term effect of silver diamine on the bacteria? And we are doing right now a study here in Indiana to look at the cost savings. When you compare the use of silver diamine against the traditional option, which the traditional option is to do the high speed and then low speed, clean the cavity, and then put the material, and then trying to compare if it's a difference. And we are looking for clinical guidelines. And again, I think so they are, in these days, more and more studies coming from best evidence of using the silver diamine. So the American Academy of Pediatric Dentistry, they put together a base dentistry committee, and they put the silver diamine guidelines, and that's what we are using currently in our program. And these guidelines, basically, they will tell us exactly how we can use the silver diamine, and the good, the bad, and the ugly of using the silver diamine, and the steps that we need to use. So this is just, and it's coming from the guidelines, so I will just go very quick here. So the mean silver diamine solution applied to the teeth, the concentration is about 7.7 milligrams. This is a 4-hour observation period. The max serum concentration is about 1.86. I don't want you guys to remember these numbers. Fluoride, advantage of the use of silver diamine: control of pain, is no invasive. Control of infection, we talk about that. It's a pretty high pH, plus the silver diamine will kill the bacteria who is present in the cavity. Easy to use, and is affordable. You can buy a little bottle, and then that little bottle you can use it several times with several patients. And also the time that you use for application is minimal time. I think so this is the most important slide, honestly, about silver diamine before we move into other topics. So for the residents who are listening to this webinar, I hope that you are with me in the same page, that the case selection is critical. Which patient will have the biggest benefit or the max benefit of the use of silver diamine, and obviously which patients they will not have any benefit, and we need to do something different. And I think so that's when we need to put our brain to the side. I have 2 patients. I have little Johnny, and for little Johnny is appropriate to use silver diamine, but I have a little Martha, a different patient in the chair, and maybe for her, because, and we are going to talk about that in a minute, because these reasons maybe is not indicated to use silver diamine. That's what I call critical judgment. The same when I talk about radiology, that's your call, you know, and that's when you need to use your brain. There is not a computer who will tell you that. You know, you need to order a periepical, your brain is telling you that, and because you have a reason, and here is the same, you have a reason to use silver diamine or not. So caries control approach. So when the caries is in the enamel in the dentin and is not encroaching the pulp, and also the patient is not having a spontaneous pain, I think so that's one of the main criteria. Obviously, if you take a radiograph and the decay is into the pulp, you see radiographic signs who tell you that this is a necrotic pulp or irreversible pulpitis. Obviously, is out of the picture that you are not going to use silver diamine. So you need to have patients' consent and parents' consent. And you know, one of the problems of silver diamine is that going to change the color of, is going to give you a black color, and parents need to be informed about that. And the goals of the treatment is to stop the caries, prevent, delay surgical treatment with sedation or GA. That's one of the ways that I use silver diamine in my practice. When I have children under the age of 3, and I try not to take kids under the age of 3 to general anesthesia or any other form of sedation. That's a safe age limit. So for that kid, they have decay in all 4 front maxillary incisors, and the kid is only 2-year-old. I think so silver diamine will be a perfect example of, it will prevent, stop the decay, and also delay the treatment. So what I tell the parents is, using the silver diamine now, we can wait until the kid is a little bit older, and either I can provide treatment in the chair or I can go to general anesthesia, but the kid will be older than 3. Stop caries progression in pulp damage. And after that, subsequent restoration is when you really need to think about the function. This is the point that I was mentioning at the beginning, that sometimes it's a hit, it's a crash between public health dentistry and pediatric dentistry. I know we're supposed to be in the same page, but sometimes I get a little bit concerned when I, read, and I belong to several groups of public health dentists. And sometimes the idea is, no, you can just go and apply silver diamine with a brush, with a little whatever, and then that's it. And then see you later. But doing that, I don't think so we are restoring function and aesthetics. And that's what I kind of, sometimes I get some nice arguments with some of my colleagues when they just go to the community and apply silver diamine without thinking in function. I think so that kid who I'm applying silver diamine, I think so deserves also to restore the function. That's my opinion. So we do, how we apply the silver diamine, we do an informed consent, make sure that mom and dad, they know. We wear gloves, I'm sure you do the same. And then in a little paper tray, we bring the silver diamine, 1 drop solution, and then we apply that with a little micro brush. And then we apply that, we try to isolate the tooth with cotton rolls. We dry that before. And then we kind of moist the carious lesion with the smallest amount of silver diamine solution with a micro brush. I will suggest to use goggles when you are using that with the patient. I know the little ones, it's difficult to keep the goggles, but I have a friend of mine not too long ago who told me that by accident, she was applying the silver diamine and then the patient moved and the silver diamine ended up in the eyes of the patient. So I think so we need to be careful, or at least try to protect the eyes. So we moist the carious lesion for about 2 to 3 minutes. And then the recommendation is not to treat more than 5 teeth at the same time. That's the recommendation here. I don't know in Saudi Arabia, but here in America, we don't want to do the whole mouth. And the reason is, you know, sometimes it's difficult to keep the silver diamine limited to only the areas of caries. We don't want to put silver diamine everywhere because we can have some burns of the oral mucosa. So we need to be careful. So if I need to put silver diamine in a lot of different places, I will try to divide that in a couple of appointments. So then the follow-up alternatives, you know, I don't like the first one. This is from the guidelines. Leave the teeth and restore until the child is older. Well, depending what do you mean older. So if you want to leave the tooth and restore until the kid is 8, and you just place silver diamine at the age of 2, that means that you are going to leave that tooth without any function for 6 years. And I disagree with that. Consider restoration. And then the next bullet point is something that, again, I would love to have a seminar about this. Is about atraumatic restoration techniques, which you can put the silver diamine and then you can put a glass ionomer. Some people call that the SMART technique. It's SMART, S-M-A-R-T technique. You put the silver diamine and then over the silver diamine, you can put a GI or you can put any other material that you want, a biodentin or MTA or whatever you want it, with the idea that you are going to restore in some way the function of the tooth. Okay. I love these webinars. I think so we are doing perfect. So let's go a little bit about the whole technique. And if you are sleeping, please wake up. I'm going to look at your eyes. Don't take a nap. Well, in Saudi Arabia, it's almost 9 p.m. So if you take a nap, I guess will be a permanent nap until tomorrow. So let's say a few words about the whole technique. Again, I didn't ask before. I supposed to do my homework before and ask if you do the whole technique in Saudi Arabia. Here in the States, we do the whole technique. I am not a fanatic of the whole technique. I think so in some cases work. In some cases, with my hands, it doesn't work. Some of my colleagues, they use a lot of the, you know, with a lot of the patient whole technique. Just next to me, next office is Dr. Dean. As you know, Jeff Dean is the editor of the McDonald textbook. And Jeff Dean is, he is a very strong supporter of the whole technique. In fact, one of the main studies of the whole technique is from Indiana. I was not part of the study because I came to Indiana 6 years ago, and the study was published exactly when I came. But so Indiana in some way is associated with the whole technique. So what is the whole technique? So the whole technique is basically placing a crown in a tooth without any preparation. That's it. You just have a tooth and you may actually go with a spoon. You can excavate a little bit of lesion and then you just put the crown. I think so it's easy if you have an open contact. You know, when you have a close contact, I know in the whole technique, they say you can ask the patient to bite as hard as the patient can. But honestly, sometimes I found that very challenging to bite until you don't need to put anesthesia, you don't need to put anything. So the whole technique was actually, the creator was Dr. Hall, And she is a Scottish from Scotland dentist. And I guess she started to use this technique. I really don't know the details why. Maybe she was in the middle of the field and not dental offices, whatever. And she just started to see a lot of decay and put these crowns, like ask the patient to buy it. So she started to do that. And then in Scotland, they put together the University of Dundee, which is a wonderful university. It's one of the best universities in the world. They put together this user manual. They call the whole technique a minimal intervention, child-centered approach of treating caries primary teeth. So the whole technique, as you can see here in this picture, when I do the whole technique in my office, probably the tooth that usually I will at least think about the whole technique is the mandibular first primary molars. One of the reasons is sometimes it seems like the space between the first primary molar and the canine, we call the primate space, sometimes is open, and that facilitates the crown to slide into the tooth. Second molars, I found that a little bit more difficult. And what I found very challenging is to do two teeth together. So the whole technique, there are a lot of articles. And again, if you get my PowerPoint, you can look at the articles by yourself. But if you are skeptical and you don't believe in the whole technique, well, I can show you some articles that they show that they works. So this is one of the articles, 2 years in about 124 teeth treated with whole technique compared with 124 teeth with conventional restoration. So high speed, 169, going around the tooth and putting that. And they found in this study that the whole technique compared with the traditional technique, the whole technique will have less failures, major and minor, than doing the traditional technique. And this is from the same patient satisfaction was better. Obviously, patients will feel better because you don't need to numb. So they feel that they do better with that. And negative behavior was higher with the conventional technique. The conventional technique, again, is placing the rubber dam, going around with the 169, and then putting the crown. So it seems like the whole technique is better in terms of negative behavior. And finally, let me go directly to, before I go to the study from us here in Indiana, let me just go briefly with the technique. So no caries removal, no local anesthesia, no preparation. The study showed better outcomes from whole technique that intraoral restoration, no significant difference between the success of whole technique and traditional stainless steel crowns, more negative behavior of the kids. So this is the example. You have this decay on the first maxillary primary molar, you can see there. And then this is how we ended up putting that crowns using the whole technique. And this is the study from Indiana. It was published in the Journal of the American Medical Association in 2014, exactly when I came here. And Dr. Dean and other faculty here from Indiana. And they compare the whole technique compared with the conventional stainless steel crown. This is a retrospective chart review. And the conclusion from Dr. Dean's study is similar success rate. So it was kind of the same using the whole technique or using the traditional technique. Okay, that's what I have about the whole technique. I really don't want to get into more details. I have a lot of more cases and more studies, but you know, this webinar, we don't have a lot of time, so I need to, and I promise no emergencies will happen today. I close, my door is locked, so nobody can come in even if they want to come here. So let's go with sealants. I know some of you, and especially the residents, I can imagine if I'm a resident, listen, this guy is me. Well, what this doctor is going to tell me about sealants? You know, sealant seems to be something that we have been doing forever. And it seems like you know, what is the point of doing sealants? And well, let me tell you a few things about sealants. I think it's interesting. When I was in dental school in the 80s, the sealants just came. And I remember, you know, mixing two different things. So the sealants, really the progress of the material is amazing. So let's have a few words about sealants. I hope that you still engage with my webinar. I hope that you are not taking a nap. So isolation is the key. I really don't know. When I went to the kingdom, I was so impressed about the technology. The dentistry in the kingdom of Saudi Arabia is on the top of the technology. So I'm sure you are using Isolite, probably is familiar for you, or you are using rubber dam. You know, and really one of the key of placing a sealant is having a good isolation. I tell the resident that it sounds pretty straightforward. Okay, you just go and do an isolation, but when you are working with a patient, you know, sometimes isolation is challenge. You tell the patient, please don't move your tongue. And then as soon as you tell the patient, don't move the tongue, the patient will start to move the tongue. And you tell the patient, please don't close. And as soon as you tell the patient, please don't close, they close. So, and if you really want to make sure that the sealants are doing what they're supposed to do, they're supposed to be there for 3 to 5 years, 3 to 5 years. And if you really are asking yourself how I will guarantee that a sealant will be for 3 years, the answer is I need to place it with a good isolation. In my dental practice, we guarantee sealant. So in other words, if I place a sealant and next year the sealant is not there, I need to pay for that. I will pay, my office will pay for that. So I really need to place the sealants in a way that they will survive 3 to 5 years, because otherwise the insurance companies are not going to reimburse me back again. And also I feel bad if I charge again. I think so it's not ethical to charge for sealants every 6 months. So when we place a sealant, isolation is the key. I'm using dry shield. I forgot, oh my God, I forgot to say something so important at the beginning of the webinar. I don't have any financial conflict to disclose. So I'm not receiving any monies for any companies who is telling me to say things. I am absolutely unbiased. But sometimes, you know, like a dry shield is a commercial name, but dry shield is the one that you see on the right up. That's a system that I use, and I found that pretty easy to use with my patients. So you can use rubber dam or whatever you want to use. So we know that 90% of the caries in permanent teeth, they occur in the occlusal surface. I'm not going to go into the etiology of caries, just one slide. As you know, immature tooth enamel has a high organic content, is more permeable, more susceptible to caries attack. So the pit and fissure morphology of the occlusal surface of the molars, that facilitates the plaque retention. And so enamel of pits and fissures is thinner, in my experience, accelerate demineralizations. And then molars erupt over 1.5 to 2.5 years. So during that time, when the molar is coming into the mouth, that will be enough time for decay, for having dental caries. So that is important when we want to prevent that. And also fluoride is less effective on occlusal surface than a smooth surface. So we are using currently here in the US, we use the American Dental Association caries classification system. And why it's important to mention here is because in a minute, I will tell you the guidelines of placing sealants. And so we all need to be in the same page about what is the meaning of a non-cavitated caries lesion. And then non-cavitated, we already talked about that in the beginning of the webinar. So non-cavitated caries lesion is the initial caries lesion development before cavitation occurs. So if you look at the graphic in the bottom, the caries lesion go from sound surface, initial mineral loss, moderate mineral loss, and then advanced mineral loss. So the increase in mineral loss is from the sound to initial, and then the cavitated is when you have moderate mineral loss. And this is also coming from the ADA classification system. So let me click so you can see that. Oh my God, I'm sorry, so quick. So you go from sound to initial, moderate to advanced. So the sealants are indicated in visually non-cavitated or early cavitated caries lesions. And then you can follow this classification. We are going to go directly into the recommendations. So these are the recommendations for the sealants, something that I really encourage all pediatric dentists to use. I use sealants in my office, and I'm sure the faculty and the experienced pediatric dentists who are listening to this webinar and the residents who are in the process of getting out of and practicing pediatric dentistry, sealants need to be one of your best friends. I honestly believe that sealants is one of the best tools that I have in my office to really make an impact in my patients in terms of preventing dental caries. So sealants are effective in preventing and stopping pit and fissure occlusal caries lesions. Listen to this, on primary, and permanent molars. Why I said 5 times primary? Because for many, many years, the idea was that sealants are not really effective in primary teeth. But as I'm sure you are aware, not too long ago, we saw a couple of meta-analyses, one published in Pediatric Dentistry, which is the journal of our specialty here in the US, about kind of going against that idea that sealants were not effective in primary teeth. Sealants can be very effective in primary teeth according to the meta-analysis in this publication not too long ago. The issue is, at least here in the United States, reimbursement, the insurance companies are not really on board of paying sealants in primary teeth. So we have sometimes the problem of, I can place a sealant in a primary tooth, but the insurance company is not going to pay me for that. And obviously permanent teeth. So sealants can minimize the progression of non-cavitated occlusal caries lesions. That's the initial lesion. So the recommendation is to place sealants over non-cavitated caries lesions. I know the concept of cavitation is a concept that is subjective. If I put you 100 different teeth with decay in front of you and I ask you which ones are cavitated, which ones are not cavitated, we may have some disagreement. So this is the gray line. And sometimes it's difficult to put a clear cut. You know, the guidelines will tell you you can put sealants over non-cavitated caries lesion, but sometimes, you know, that guidelines are a little bit gray, and that's the clinical judgment. The guidelines are unable to provide specific recommendations of the relative merits of any type of sealants. We have different types of sealants. This is interesting. I don't know if you are doing this in the kingdom, but here in the United States, when we are placing a sealant, we etch, and I am obsessive compulsive with the etching. I wait the time that I need to wait, and then we rinse, and then we apply bonding, the same bonding that we use for composites. So I apply the etch, rinse, and then I apply the bonding, light cure, and then I apply the sealant. And that show, and they not just only, you know, articles that they use for this symposium or for these guidelines in the sealant recommendations, but there are several articles that show that when you bond, I know it's an extra step, and sometimes having an extra step could be a problem because it's more time, chair time, and you have a kid who is moving. But the idea of placing the bonding, it works in terms of retention. So the 2008 ADA guidelines, they suggest, I don't like to use the self-etching bonding agents. It seems like they provide less retention than the etch technique. We are not using any routine mechanical preparation. I'm sure you guys in the Kingdom of Saudi Arabia, you are not using it, or you are not doing any mechanical preparation. When possible, we try to do that always, which is the forehand dentistry. And then something that I tell my residents, and sometimes when I would the residents in the clinic, it's funny because sometimes residents, when they take the Explorer, it seems like they like to use the Explorer like this, and you need to try to be away from that. The Explorer need to be used very gentle, because when you really push the Explorer into the enamel, you can break down that very thin and fragile enamel crystals, and then you can break down there, and then you can actually do the opposite. Doing the Explorer pretty hard, you can facilitate the progression of the dental caries. So I am always very gentle. Sometimes my residents, they make fun of me because they say, you know, you are the most gentle dentist using the Explorer. And I like it. I like to have the title of the gentle dentist, especially with the Explorer. When I'm looking, observing my residents, and they take this Explorer and they really go, I say, well, you can look with your eyes, and without the Explorer, you can have a pretty good assessment of the dental caries. So there is a lot of evidence. There is thousands of articles, you know, data from 9 randomized clinical trials about the use of sealants compared with the no use of sealants shows that decreases the incidence of occlusal caries in permanent molars by 76%. Just that sentence is enough to love sealants, honestly. That sentence of decreasing occlusal caries by 76% is enough to say, I love the sealants. I love the sealants. So, and again, you can go by yourself and read all this information. Something interesting about the glass ionomer sealants, I'm sure you use the glass ionomer sealants. I use often glass ionomer as my sealant material, especially the ones with low viscosity glass ionomers. I love to do that in some circumstances as the sealant. For those who are listening to this webinar, especially faculty and pediatric dentist who has been practicing for a long time, you know this. For the residents who are just learning, as I said before, one of the most critical issues of the sealants is the isolation. So you cannot have a good isolation if you cannot guarantee that the tooth will be dry. Especially imagine if you have a first permanent molars who are coming in, they are partially erupted, half of the tooth is covered by gums, and the teeth is a high risk teeth for dental caries. So sometimes isolation is almost impossible. So when I have that situation, what I do is I use GI. And I know GIs are not as effective in terms of retention compared with sealants. GI will give me some time of protection, and then when the teeth is fully erupted and I can have a better isolation, then I can use the regular sealants. So there is no difference in caries development between the regular base sealants and the glass ionomer, but obviously the retention of the conventional sealants is much better. And I think so that is what we need to use when we cannot have a good sealant, when we cannot have a good isolation. So the technique of the sealant, there is not a lot of changes from what we learned. We need to determine the need for the sealant, that the meaning of clinical judgment. Greatest benefit in patients with a high risk. We clear the surface, then we use the edge, then after the edge, we are using the bonding, and then we place the sealant over that. And so that is the technique, and I don't think so. The only thing that we do different here, as I mentioned before, is we use bonding, and we don't recommend the use of self-etching bonding systems. We prefer to use the bonding. I mean, we etch, then we rinse, dry, bond, light, and then after the light, we go ahead and put the sealant. And then we rinse, after we place the sealant and we cure, we rinse for about 5 to 10 seconds or 20 to 30 seconds, depending on the different options that we have. Okay, so that is the sealants. Let's keep going with the agenda. This webinar so far is fantastic. We are moving in a good pace and we are doing great. Let's talk about resin infiltration. Resin infiltration is one of the things that I am a fanatic of resin infiltration. I do that a lot in my office. I wish when I was young, my mom used to take me to see the dentist. And I wish my dentist, this is obviously when I was little, I wish the resin infiltration was available during that time, because I have a lot of class 2 restorations in my teeth, and a class 2 eventually will fail, and eventually you will need a crown, eventually you will need root canal, so you go into a sequence. So resin infiltration is one of the most contemporary techniques that we have in pediatric dentistry is non-invasive. We don't need to use high speed. We don't need to use any aerosols. And honestly, resin infiltration is a wonderful alternative of stopping the progression of the dental caries and avoid drilling the tooth, with all the implications that you can imagine. When once you make a hole in a tooth, that hole will stay forever. So resin infiltration really became a great alternative. We do a lot of resin infiltration here in our program. I need to be careful before I click, because as far as I know, here in the United States, we only have one resin infiltration system available. I'm sure in the near future, we are going to have more. So some people call resin infiltration as the ICON system, ICON system. But ICON system, ICON is the name, is a brand name. And so when you say, oh, I'm using the ICON system, it's like you are using the Johnson & Johnson system or whatever other name. So that's a particular name, brand name. And I will show you some pictures, because that's the system that I'm using, but I am not sponsored by the ICON system by no means. So resin infiltration, let's go and see. So resin infiltration can be used for interproximal caries lesion, but also can be used for white spot lesions, the ones on the facial of the central incisors, or facial in any other place. Again, it's a non-invasive technique. It's also a wonderful alternative when you have patients after they complete braces and they take out the braces, and then sometimes you see this demineralized white spot lesions after they take the braces. So that is also a nice alternative. Resin infiltration may reduce the lesion progression and minimize the secondary caries. requires no preparation, no restoration margins. The picture that you see over your right side, that is coming from the Icon system. And they put that picture just to make sure that the dentist understands that the resin infiltration systems can be used up to D1. And that D1 is coming from the American Dental Association classification of dental caries. So I'm sure you are familiar with that. If you are not, let's go from left to right. So left, you have the tooth without dental caries, and then you have E1. E1 is when the caries is just in 1/3 of the enamel. This is what we call an incipient lesion, perfect for resin infiltration. E2 is just in the enamel, but a difference between E1 and E2 is deeper, but it's not yet into the enamel dental junction. And then we have D1, D2, D3, which is into the dentin. D1 is just getting into the dentin, and the only way to know this is by radiographs. And one of the things here, and this is clinical judgment, clinical judgment, clinical judgment, clinical judgment, sometimes radiographs underestimate how deep is the caries lesion. So that is your call. The radiograph is not going to tell you, hi, Dr. Yepes, I am the Bidewin. I am looking at the caries lesion between A and B. Oh, it's D1. That is your brain. So E1 is easy. E2 is easy. The problem is between D1 and D2. The D1 is just getting into the dentin, and the D2 is halfway into the dentin. D3 is easy because D3 is into the pulse chamber. So the extremes are easy. The resin infiltration system is designed for E1, E2, D1, and they don't recommend this system for D2, obviously not D3. So that's the clinical judgment that you need to do. So the component, this is not radiopaque. This is one also, probably one of the disadvantages of the resin infiltration system is once you place it, you take a radiograph, you don't see that, you don't see it. And that could be a potential problem because if you want to follow up and make sure that you place it correctly, you don't see that on the radiographs. The components are ethanol, 15% hydrochloric acid, and then the infiltrant, which is the resin, is very fluid, is methacrylate-based resin matrix, which is coming with initiators and adhesives. And again, the indication go from non-cavitated to D1. So this is from the American Dental Association 2015, and this is the reference manual. I'm sure you use that in the kingdom. And this is the reference manual. I have it here in my hands. I keep this in my office, and this is always, I hit in my face because if we are pediatric dentists, this is here in the United States, this is the best evidence that you can find of anything that you do in pediatric dentistry. I also want to do something that, this is the McDonald textbook, and this textbook is from here, and we are working, is coming this fall, the new edition. This is the 10th edition. We are working into the 11th edition, which is coming in the fall, and Dr. Dean invited me to be one of the co-editors. And this is an honor that I never imagined in my life my name will be in the textbook, but I love it. So the reference manual, the one that I show you, the blue one, and this is copy from the reference manual, from randomized controlled trials, there is evidence in favor of resin infiltration as the treatment option for small non-cavitated interproximal caries lesions from E1 to D1. And based on these clinical trials, resin infiltration significantly improved the clinical appearance of white spot lesions. So a little bit why we use the 50% hydrochloric acid. That's the equivalent of the etch. When we are doing a sealant or when we are doing a composite, we etch with orthophosphoric acid at 37%. But when we are using the resin infiltration technique, we use hydrochloric acid at 15%. And the reason why we don't use the 37% orthophosphoric acid is because we really want to go deeper into the enamel. We want to create a better mechanical retention. And as you see in this slide, you see that the mechanical retention is higher with the 15% hydrochloric acid. It goes deeper into the enamel. So the infiltration is, the idea is we are going to infiltrate the caries lesion pores or holes. And doing that, we are going to stop the lesion progression by establishing a diffusion barrier. And also when we have white spot lesions I don't have, let me see, I don't have any spot lesions. I used to have one in my colleague, he did this. I hate it. I used to have one white spot lesion here. So using the resin infiltration, you improve the aesthetics by replacing the demineralized enamel with an infiltrant with similar refractory index. So this is the Icon kit. This is the one that that we are using here. It comes with that, with the syringes. And let me tell you the technique. I'm sure in your programs, here in our program, we are using the Icon system. And that's one of the things that if you want to come to us and spend a couple of weeks here in our program, please do it. You can email me to my university email, or you can send me an email to the one that I will show you in a minute. And then we can work in the details. But I will, so if you are not familiar with the Icon technique or resin infiltration, you can come here and we can show you. So we clean the teeth, then you have two options. You can use, the kit is coming with green wedge, so you can put in between the teeth, so you can separate the teeth a little bit. Or this is what I do in my office, and this is usually what we do here in the program. We place orthodontic separators for about 5 to 7 days, and then we ask the patient to come back. And then once we do that, we etch for 2 minutes. Remember, we etch with the hydrochloric acid 15%. Then we rinse for 30 seconds. Then after that, we place, so the steps are, we place the separators for 1 week. Then when the patient came back, we dry, we place the etch, which is the 15% hydrochloric acid. Then we rinse. And then after that, we use ethanol. I would love to know if I have any resin in the audience, because I would like to ask you a quiz question to try to figure out why we need to put ethanol, why we need to use ethanol. Well, you can read in the slide, the use of the ethanol is to dry the interproximal area. And then we place the infiltrant for about 3 minutes, air dry, floss, and cure. And then if you want it, you can do it again for 1 minute. And then we can slide polish using the strips. I know this lecture is not, the intention is not to give you a whole lecture about the Icon system, but at least you can have an idea. So you can see, look at this lower molar, look at the lower molar, you can see a lesion on the enamel. I will say probably D1, no, maybe E2. Do you see that the clinical adjustment is important? The radiograph is not telling me, oh, I'm a E1, I'm a E2, so you need to do that. And then we isolate, and then we go through the steps, we dry, we use the edge, then we dry with ethanol, and then we go ahead and we use the infiltrant. And the infiltrant is coming with that syringe, and you put that in between, and you do that. And then you cure. Here in the United States, we have a code. And so this is probably not important for you, or I don't know, maybe in Saudi Arabia, you also have a code. But here we have a lot of fight with insurance companies because at the beginning, they didn't pay for the resin infiltration system. They pay for drilling, they pay for a class 2, but they didn't pay for the resin infiltration system. So it took for a while until the American Dental Association helped us to have a CDT code. The CDT code is Codes of Dental Terminology. That's the one that we use to submit a claim so we can get paid. And we have a code for that is resin infiltration of incipient smooth surface lesions, facial, lingual, or interproximal. And the description of the service is the placement of an infiltrating resin restoration for strengthening, stabilization, and or limiting the progression of the lesion. So that's what I have for resin infiltration systems. And again, I love it. And I using that regularly in my practice. And I hope that you are also using that in your practice. So because this lecture is about dental materials in pediatric dentistry. So if you don't mind, let me, I don't know how we are doing about time. It's 9:21 in the kingdom. Do you mind if I take about 15 more minutes? It's okay if I go, because I want to have some time for questions and answers. So it's okay if I just go a little bit more, like a 15 more minutes, no more than 50 more minutes? Okay. I hope that the answer is yes.
Yes, it's okay.
Okay, thank you so much. I really appreciate that. So I want to talk about, this lecture, I have a whole section about glass ionomers. But I think so glass ionomers, I mean, if we are doing pediatric dentistry, we are dentists, we know a lot about glass ionomers. It's one of my favorite materials, no question about that. So if you, and because we have limited amount of time and I don't want to stay for 7 hours, I am just going to skip glass ionomers, but I'm going to land, or I'm going to start from resin-modified glass ionomers. So what I'm going to do is I'm going to switch from resin infiltration, which we just reviewed that, and I'm going to go directly into resin-modified GIs. So I'm skipping the section of GI. But again, if anybody wants to know or wants to learn a little bit more about GIs, let me know and I will give you the whole PowerPoint. So the resin-modified GI we call RMGIs. The resin-modified, I don't know if some of you are preparing your boards, and I am one. Here in America, we have a board preparation course for the pediatric dental boards, and I'm one of the speakers. So I am very familiar with, and I provide courses of board preparation for my residents. So this is kind of a board question. This is important. If you are a resident, this is important for you to know. So what is a resin-modified glass ionomers? I use a lot of resin-modified glass ionomers in my practice. Yesterday, I was in the OR, and I use with 2 different patients, I use a lot of resin-modified glass ionomers. I think so they are a great alternative. So a resin-modified glass ionomer is a conventional glass ionomer formulation with addition of a resin monomer or comonomer of acrylic acid and methacrylate, such as hydroxyethyl methacrylate. So it's a combination of GI and resin. So there is an acid-base polymerization that happened with the GI, supplemented by a resin-like cure polymerization. So we have 2 different processes going at the same time. We have a chemical polymerization, and also we have a like cure polymerization. So this material, the resin-modified glass ionomers, they demonstrate triple hardening. They have an initial curing using the light. So the resin component is very sensitive to the light. So that's the initial process. Then we have a chemical resin cure. And then number 3, we have a GI-based neutralization that happened over time. And that is the final process, the chemical process of the GI. So it's a very step-by-step process that goes from the light, then the chemical, and then it will take some time until it's fully polymerized. So why we want to combine? Great question. Why we want to combine resins with GI? Why we just don't want to use just GI? What is the advantage of using GIs? Well, interesting. This combination of resin-modified glass ionomers, they are the same properties of the GI. So remember, one of the good properties of the GIs is they release fluoride. I need to be careful with that, because it doesn't mean that when you place a GI will release fluoride the rest of the life, which is not true. They may release fluoride at the beginning, then we need to recharge. So we need to reapply fluoride. So the fluoride, the GI will be a reservoir and will kind of release fluoride over time. So with this combination of resin-modified glass ionomers, we have the good properties of conventional GIs, plus we have a better wear resistant and aesthetics when we add the composite, and we also add the cure, the light cure. After we prepare the tooth, we use the conditioner, which different manufacturers, they use different conditioners. In some companies, you don't need to, so you do the prep. Yesterday, I have the perfect patient for a resin-modified glass ionomers. I have a patient who, with a non-Hodgkin lymphoma, the patient in chemotherapy, with a terrible oral health condition. You know, I took some pictures. I didn't have the time to put the pictures in this PowerPoint, but huge caries lesions, a patient with a huge susceptibility for dental caries. And we went in the OR with, you know, pretty much every single tooth in the mouth will need a restoration. This is the problem. If I go with resin, you know, resins will not offer the same properties of GI, especially the release of the fluoride. And so that patient was perfect for the GI. But in the top of that, the resin-modified glass ionomers will let me be a little bit more aesthetic and also increase the wear resistance of the material. So we ended up using resin-modified glass ionomers. So you prep the tooth, and then after you prep the tooth, you can use the conditioner. Interesting, you can also use self-etch. you can use self-etching techniques, or you can use the regular etch that you use for composite. You can use 37% orthophosphoric acid. I prefer to use the conditioner who is coming with the material, so that's what I use. And then after that, we place the material and we do the cure. So with the resin-modified glass ionomers, we do the sandwich technique. I'm sure you are familiar with the sandwich technique. When we do the sandwich technique, the resin-modified glass ionomers is used to replace the dentin. And then over the dentin, we put the composite. And then the composite will be the enamel replacement, and the resin-modified glass ionomer will be the dentin. Unfortunately, you know, it will take me a lot of time, but in this lecture, I have a section about dentin substitutes. And dentin substitutes are new materials that we have available in pediatric dentistry to really, as the name said, dentin substitutes to be used as the dentin. But for now, for this section of the webinar, the resin-modified glass ionomers can be used as a dentin in the sandwich technique. So you prep the tooth, then you place the resin-modified glass ionomer as a dentin, and then on the top of that, you use a composite as the enamel. Now, I mentioned that, and this is not a webinar about that, but there is also the smart technique, I mentioned that, which you use actually silver diamine as the first step. You place silver diamine, and then over the top of the silver diamine, you use a resin-modified glass ionomer, and then you can put a composite at the end. So you start with the silver diamine, and that's the smart technique. So the idea is the ionomer bonds to the tooth, and the advantage of the resin-modified glass ionomers, also they decrease the marginal leakage, reduce the postoperative sensitivity, reduce the effect of the polymerization shrinkage, and improve the aesthetics over GI only. So the sandwich technique, you put the composite on the top. There is two different sandwich techniques. There is the open sandwich technique. What is in the open sandwich technique, there is no remaining enamel at the gingival margin. And then you place the resin-modified glass ionomer in the subgingival interproximal box, occlusal and gingival. One of the good advantages of the resin-modified glass ionomers, and I mentioned I love it, is because it's less sensitive to moist than the conventional composite. So that's a good material in places that is difficult to have a good isolation. And then we have the close, I'm sorry, I'm going too quick here. And it says open is close. In the close technique, we have some remaining enamel at the gingival margin. So in the close technique, you place the GI. In the example that I'm showing there, that's Fuji 2. Then you light cure, then you bond, then you light cure for the final composite. You can replace the GI for resin-modified glass ionomers, and then you at the end, you put your composite at the end. What is the evidence? The resin-modified glass ionomers may be considered for class 1 in primary teeth. In class 2, listen, in class 2, that will be the open sandwich technique. And in permanent teeth with class 5 are ideally for resin-modified glass ionomer. As I mentioned before, condition of the dentin may improve the success rate. So I prefer to do the conditioner before I place the resin-modified glass ionomer. Remember, you can use the conditioner who is coming with the kit, or you can use the 37% orthophosphoric acid. It's not recommended to do the cabo surface veiling, something that we used to recommend to take a fine diamond burr and go in the cabo surface and try to bi-level or try to smooth that angle. Is not recommended when we are using the resin-modified glass ionomer technique, because we now know in these days that doing that increases the potential of marginal fractures. Okay, so I will, I will need to stop here because we don't have more time, but I would like to say a few words about the dentin substitutes. And I am a fanatic of the dentin substitutes. I think so. As a pediatric dentist, I hope that everybody's listening to this webinar and you are familiar with this. And the dentin substitutes, basically we have two options. We have the MTA, or the mineral trioxide aggregate, or we have the biodentin. And so because time and is always is right now 9:31, it's 2:31 here in America. I have more time, but I don't want to abuse your time. I'm going to stop here in dental substitutes. And I really want, I hope that I will get invited again. And you know, one of the things, and you mentioned that, Dr. Ahmad, and one of the things that this, and Dr. Ali, one of the things that the pandemic is helping us is to create these collaborations and these webinars, long distance, but it seems like I'm there. And I hope someday to have the opportunity to go to the kingdom. I really love to do it, and I hope that I will see everybody face to face. Okay, so we can have about 15 minutes for questions and answers. I don't know how you want to moderate that. I know that we have already some QE. I can read it. Let me see.
First of all, thank you. I can't say Prof because we are close to July now. Prof. Yepes, for this informative, comprehensive review of the dental material and pediatric dentistry. I have some questions that I picked from the list, so I can read it for you and maybe you can answer. I know you hear me, or?
I can hear you perfectly.
Yeah. Okay,
absolutely
good.
Perfect.
Good. So I have a question from Dr. Yasser. In case of close contact, when we use the Hall technique, can we put the ortho separator to open the contact?
Yes, you can do that. That is what, you know, here in the United States, some dentists are fanatics of the Hall technique. Some dentists hate the Hall technique. Some dentists are in the middle. I am in the middle. I'm not a fanatic. I don't hate it. But because I'm in the middle, sometimes if it's a single tooth, imagine it's the first mandibular primary molar with a large occlusal distal caries lesion. And this is a child of difficult behavior. And, you know, I can put the separators, I can do the ortho separators, and then I can bring the patient 4 or 5 days after that. And for sure, when I do that, that will help. As soon as I put the crown, will help the crown to go down. But believe it or not, the ones who are fanatics, the ones who do Hall technique all the time, they say that they don't use very often the separator. They just put the tooth, and then they ask the patient to bite as hard as possible. Again, I try to do that in the office, but sometimes you put the crown and the patient, even biting pretty hard, I can tell you that the crown is not going down. So it's difficult. So yeah. Honestly, depending where you are, if you are a fanatic, you love it. If you are not, you hate it. If you are in the middle, sometimes you like it, sometimes not. That's me.
Okay. The other question is why we are talking about silver diamide fluoride and not mentioning the nano-silver fluoride, which doesn't stay in the teeth.
Yeah, we here in the United States, the nano-silver fluoride is just, I am not very familiar. I know that we have a product available in the market. So far, up to today, I haven't the opportunity to use it. I think so. I hear one of the problems, and this is, again, this is the perception. Maybe my perception is completely, you know, fake, but I hear that one of the problems is that you need to include one more step. I don't know. So I will need to have the opportunity to use the material and then see a little bit more articles and research, because that would be wonderful. Honestly, if the color, we can get over the color, that would be perfect. I mean, if we can place something equal effective, a silver diamine 38%, equal effective, and it's not going to change the color, well, that will be an absolutely welcome to my practice.
By the way, I agree with you that restoring the functionality is important for the tooth, but there are some community that they have a dental caries is more prevalence. So maybe, and this is affecting the dental system, because here in Saudi Arabia, most of the health services is free. So we have a lot of waiting lists. Maybe the SDF can be utilized to stop the progression of the dental caries until the time that you can schedule those patients for restoring their teeth. Is there any study showed that a recurrency of caries without restoring the functionality of the tooth?
Excellent question. Excellent question. Not too long ago, I gave a webinar for all the diplomates of the American Board of Pediatric Dentistry here in the United States about non-aerosol dentistry. That was the title, non-aerosol dentistry. So that question was one of my first homeworks. I want to find out, I want to really go and find, and the answer is there are a few studies, short follow-up, not really 10 years, that they show that when you place silver diamine and you don't place anything else, you don't restore the tooth, you just place the silver diamine, between 15 to 18%, just to remember, maybe 15%, 15% will fail. In other words, the caries will continue the progression and that tooth will fail. So there is some, and I think so over the time, we probably will see more articles with long follow-up. But personally, and again, depending on access to care, and I said this, I'm a public health dentist, so I understand that depending, there are some places of the world that caries is what I tell my residents, that you see caries in the clothes. I mean, you see caries in the shirt. Hey, caries, how are you? So there are places of the world that caries is really prevalent and access to care is almost impossible. So I see that silver diamine will have a benefit, no question about that. But I think so the use of silver diamine, at least in my mind, after I use silver diamine, I'm always looking for that next step. I don't think so I will just place silver diamine and tell the parents, that's it, we are not going to do anything else. I will place the silver diamine and then I will, thinking how I can restore the function of that tooth. And so, good question. That's an excellent question.
The other question related to SDF is why we don't use SDF for non-cavitated proximal caries.
Yeah, I think so. The use of silver diamine for proximal is difficult to take the material into the proximal area. I don't know, we can use something similar to the resin infiltration system. So, but as far as today, June of 2020, we don't have a way to carry the silver diamine into the interproximal area. You may actually can paint it and then you can take a floss up and down, up and down, up and down. Yeah, but it's different when you use the resin infiltration, because with the resin infiltration, you place the syringe, which comes with a device in the front that fits exactly in the middle. So when you infiltrate, the material will go into the proximal area. With the silver diamine, honestly, I don't know. I don't use silver diamine for interproximal caries lesions. I don't use it.
Okay, I think maybe we'll do one or two questions because I see Dr. Imad now is appearing in the screen. So why we don't use the question, can we use the whole technique in MIH patient?
Oh, okay. I have a completely different lecture about the molar hypomineralization syndrome, or MIH. And the answer to that question is, until we can have a webinar about that, the answer to that question is yes, you can do that. You can do the whole technique in the molar hypomineralization incisal. I don't know how you call it in Saudi Arabia, probably the same that we call it here. Yeah, you can do it. Absolutely. Okay. I am not, it's maybe my hands. Look at my hands. They are small. So I have short fingers. My brain is short. I am not too successful with the whole technique. I try. And believe me, I don't know why. But Dr. Dean, which is my neighbor, he uses the whole technique all the time. So I think it's related with my hands. Short fingers, and I don't know.
Okay, I'll just end with this nice comment from one of the attendees. She said that this is really amazing and informative lecture. The time gone so fast. Please, can we have the presentation? This is, you said yes. Also, they just gonna email you, and then you're gonna share it with them. Also, if the prof does not mind to, or doesn't mind, we would like to have a lecture about most common pathogens in pediatric patients. Maybe we can arrange it, or the site can arrange
Yes,
it in the future.
With the Kingdom Pediatric Dentist and with the Kingdom Dentist, I have the greatest appreciation. And I will find time on my schedule, as much as I can, to provide as many webinars as you wanted. This is a learning experience. Yeah. This is a learning experience for me, and I love to do it. So we just need to go back and forward with emails as we did it before, and then we can find the time. I have a pretty extensive portfolio, you know, from my background, medical background in radiology and oral medicine, so we can find the time. Finally, I am going to tell you my email in case that you want to have my PowerPoint. And I hope that are you seeing my computer?
Yes, yes, yes.
Okay, I'm going to write my email here.
No, we are seeing your picture.
Okay, let me, I will, okay. Just 1 second.
Okay.
Don't go bed yet. Wait for me.
No, we were not going anywhere. Anyway.
Okay. So can you see my email there?
Maybe you can share it in the chat or
I just put my email. Can you see it there? Is there?
No, maybe they need to share your screen.
Okay, let me do that. Sorry.
Yeah.
For Kunus company, can you share the screen, please?
I just did it. Okay.
Yeah, you can put it now. Yes, now it's clear.
Okay.
Yeah, so I would like to thank you very much. So we're going to hand the mic to Dr. Ahmed. Thank you very much. I enjoyed your presentation, and I attended your presentations live, and I think it's very interesting. And I hope that one time that you will come back to Saudi Arabia, and we'll see you in Riyadh again or in Jeddah. And if you don't mind, there are many questions, so maybe they can send you their questions so you can answer it later on. Because of the sake of the time, I think we have to close the session. So Dr. Ahmed, the mic is yours.
Okay, thank you so much. Can you please share the screen, please? Kunus company. Thank you, Dr. Yefis, for the speaking at our society here in Saudi Arabia after your lunch break. And thank you so much for your informative lecture. And as a token of appreciation from the society, on behalf of the society, I would like to present a certificate of appreciation. And I will keep the promise. We'll contact you. We'll have you hopefully in July in the next webinar. We'll after we finish, we'll contact you by email and we'll arrange something. Everybody's asking or talking highly. They appreciate your talk, your lecture, the way you present to us the material. And also, I would like to say thank you to our moderator, Dr. Ali Al-Haidib, for the session today, moderating the session. And shukran to Ali, mashallah, tabarakallah. Everybody is saying hi to you, Dr. Ali. All the Saudi graduates, the old generation of the graduates saying hi to you, and they appreciate what you did to them in the previous years.
I am a teacher, and that's the best compliment that I can have from students. And as a teacher, there is nothing better in life when a student tells you thank you.
Thank you. And I would like to say thank you to our attendees. And it was an honor to have you today with us on the lecture. And hopefully we see you. We're looking forward to see you in the further lectures during the month of the rest of June and month of July. And I would like to announce on behalf of the Saudi Society of Pediatric Dentistry, our conference will be in Saturday, June 27. Return carefully. So hopefully you get all the information from the website, from Twitter, from the social media. So please join the society and please attend our lectures. And thank you so much.
Thank you, everybody.
Thank you, everybody. Good night. And enjoy
Have
the
a
rest
good
of the day.
day.
Dr.
Have a
Yunus.
good day, Prof. Yabis, and good night for the others.
Good night.